We will moving to the next session, next lecture. That is quality assurance in coagulation studies. That will be taken by Dr. Jyoti Kotwal. She is a chairperson, Department of Hematology and Clinical Pathology, Sir Gangaram Hospital, New Delhi, and she is also President, Delhi Society of Hematology. I will also like to introduce more about Dr. Jyoti. She is a distinguished medical professional, researcher, administrator, and educator. She has got a 29 years of stellar experience in pathology, hematology, and transfusion medicine, quality assurance, and laboratory management. To her academic credentials, she has done her MBBS from Lady Harding's, MD Pathology from Armed Forces Medical College from Pune, and she has also done 2 years full-time postdoc fellowship in hematology from AIIMS Delhi. She has done a advanced hematology course at IIH Mumbai, and she has also in her credential WHO fellowship in molecular genetics at KK University, Thailand. She has done FRC. She has also has a bagged FRCP from Edinburgh in 2018. To her research credentials, she has published about 158 papers. 79 are among the international and national journals of medical database, and 89 are from non-medical database. And she has supervised about 29 research projects and guided about various ICMR STS projects for MBBS students. And she has 8 students for their post-MD degree. And she is currently guiding 2 DNB super specialty hematology resident of NBE. So with such a great experience and long academic career, I will like to welcome Colonel Dr. Jyoti Kotwal to present his talk. Please, Dr. Jyoti.
Thank you, Dr. Balram, for such a nice introduction. I don't think I deserve it. And thank you, Dr. Seema, for involving me. So the topic given to me is quality assurance in coagulation studies. And I bring greetings from my hospital, Sir Gangaram Hospital, to all of you and from Delhi. And I'm not going to discuss all these, everything we know about quality assurance, but what is the aim? In coagulation, the aim is to give the right, do the right test on the right specimen and give the correct result. And as we all discuss quality, the precision is because of the calibration and the accuracy is because of the QC. And all laboratories, has already been discussed by the earlier speaker, have internal quality assurance as well as external quality assurance. And in internal quality, we run the control charts, we look at the duplicates of some samples, we look at the consistency and value of the patient's results, as well as we look at the correlation check. So that's very, very important. And why do we need it in coagulation? To enhance the diagnostic accuracy, because coagulation tests result in certain things which may lead to unsafe practices in patients. So that's very, very important, because coagulation comprises of enzymes and unstable proteins, and that's a unique challenge. So that way it's a little different from the routine clinical laboratory practices. We all know about internal quality assurance, which everyone does, and that's why everyone gets accredited. The external, we have various forums available in India and also from abroad, so everyone gets it done. It's important also to have proper reagents in your lab in a coagulation. So just to show you the PT ratio and the ISI of the various PT reagents, and as the ISI increases, your INR goes haywire and you cannot monitor the patient properly. So it's very, very important to have a PT reagent with an ISI as close to 1. So that's very important in quality assurance of your lab. And also it's the APTT reagent, which is also important. You should know which is a lupus sensitive APTT and which is a lupus non-sensitive. Because if you use a lupus sensitive APTT in your lab, then for every patient you'll be doing mixing study, because everyone will have a prolonged APTT. So it's very, very important to have specific APTT reagents for specific areas of your laboratory. And as the topic is quality assurance in a coagulation lab, there are 3 aspects to quality assurance, because it's a whole process of getting good results. The pre-analytic, which involves the specimen collection, specimen transport, specimen quality. The analytic, which is the accuracy of your results and for which you do your internal control as well as your external control, your analytic errors, your essay of your repeats, and the post analysis is how you give out the report, how you flag it, and you also keep it for record keeping for your quality assurance. So rather than going into didactic lectures, I'll just come up with few cases because coagulation quality assurance is a very vast topic. I'll just touch few aspects which are important. So like this 3-year-old child was in command when I was in the armed forces earlier in Udhampur, had a hematoma on the thigh. So the pediatrician got a PT, APTT and a platelet count done, and that's what was available there in Udhampur. So APTT was prolonged, so the sample was corrected by an accredited, reputed laboratory, and it was reported as severe dual deficiency of factor 8 and factor 9 with no flag in the results. So we talk about results flagging. So the pediatrician, considering that factor 8 deficiency is common and that's the factor which is routinely available, gave some recombinant factor 8, child did not improve. So the child was transferred to Army Hospital Research and Referral. Now, we collected a fresh sample as per the SOP, how the collection has to be done. There are guidelines. And we found that the child was only factor 9 deficient. Factor 8 was in fact increased. So why was it low in that report? Because the cold chain had not been maintained, because factor 8 and factor 5 are labile factors. So the laboratory, the equipment, the internal control, quality assurance had no issue. The calibration was beautiful of the equipment. The result was there because in that sample, factor 8 was low. It was the pre-analytic issue and the post-analytic, which should have been flagged by the person reporting out, that dual deficiency of factor 8 and 9 together is a very, very, very rare entity. There must be something wrong with the cold chain maintained. So it's very important to give accurate diagnosis, because otherwise you may give wrong treatment to these patients. So the knowledge and expertise about coagulation itself and the testing, the use of correct equipment and reagents and quality assurance, as we are discussing, becomes very, very important. So when we come to the pre-analytic, it has to be the venous sample, it has to be free flowing. Fasting is not necessary, but for prothrombotic studies, it is necessary. For von Willebrand antigen assay, it's necessary. So it should be within 1 minute of the tourniquet. It should be the first draw, ideally, or the second if you're having a cultured sample taken. So then it becomes the second draw. It should never be taken from existing heparinized indwelling catheter lines, which very often happens in the hospital. There should be avoidance of bubbles and tissue fluid contamination. And as Dr. Dasgupta had also discussed about his cases, it should be preferably collected near to the laboratory to ensure quick transfer. And the needle size, the quality of the syringes if you are using is very, very important, and overfilling and underfilling issue. Underfilling is a big problem, and that you should be very particular about, and it should be a prompt, gentle mixing. We all know the ratio of 3.2% sodium citrate to blood has to be 1:9. The test should be carried out within 4 hours at room temperature for APTT and within 24 hours for PT. It's very, very important to correct the amount of blood collected or the amount of anticoagulant depending on the hematocrit. And this becomes important in neonates and children from pediatric cardiology, because they have cyanotic heart disease and polycythemia. So you have to calculate and correct the volume of the blood to be added to 0.5 ml of sodium citrate. You can do by this formula, 16 to 4.5 divided by 100 minus the hematocrit, or you can go by this chart between 25 to 55, no issues, but above and below, you have to correct the amount of anticoagulant in the 5 ml tube. There are also graphs available which tell you, as per the hematocrit, you can calculate how much of the anticoagulant you should remove from the tube. So it's very, very important when the hematocrit is high, because then the amount of plasma is less and it will be over-citrated and you'll have prolonged coagulation tests, and that will cause a lot of issues. So coming to the sample again, you have to have centrifugation. Your centrifuge has to be calibrated, and the centrifuge should be a non-cooled centrifuge, ambient temperature, to get the platelet poor plasma. You check the quality by doing a count. It should be less than 10,000 platelets. You can do it on your cell counter on the platelet poor plasma. Very important, because there's a friend of mine and she was standardizing her lab in Jamshedpur, and she had a lot of issues with her PT and INR, and she kept on saying, ma'am, it's coming below the range, below the range. Everything was okay, everything was checked, the equipment, the reagents, and they recalibrated the equipment, and finally it was because they had a blood bank earlier, it was a cooled centrifuge and the staff was centrifuging the sample in that. At 4 degrees centigrade, if you keep it cool, factor 7 gets activated, PT will be shortened, and factor 7 SA will also become abnormal. So it's very, very important to know how to go about it and how to preserve the sample. And it's very important when you are thawing the frozen sample for coagulation studies, it should be rapidly thawed by keeping it in a water bath at 37 degrees. Otherwise, you'll get a cryoprecipitate and all your tests will go haywire. So the pre-analytic variables become very, very important. The sample collection, correct patient identification, correct phlebotomy technique, correct sample volume for the hematocrit, correct sample collection tube, then the handling during transportation, the mixing, the centrifugation, and there are the issues of patient-specific factors, both physiological and pathological. So we come to this another case of issue of D-dimer during COVID. Now, this is a true case, happened a few months back. There was a senior doctor in RML who had COVID, had increased D-dimer, IL-6, recovered, and later they just tested, everything was normal, but the D-dimer came as 2000 FEU. So there's a panic. So first thing they did, they sent it to a private lab where it came as less than 0.5 FEU. So again, there was an issue. So then they sent the sample to us. Now, it was an issue of instrument. We were also earlier, till 2 years back, doing, we had only the instrument laboratories equipment, which is photo-optic, and we were doing our D-dimers on that. But whenever there is lipemia, whenever there's icterus or some other issue, the photo-optic can have problems. So we shifted to, kept a Stago equipment just to do our D-dimers. So when we did it on the Stago, and the private lab had also done it on the Stago, it was a normal D-dimer, whereas there was some pre-analytic issue of something in the plasma which was giving false positive D-dimer on the photo-optic equipment. And following this, I had discussion with my physician friends in Bangalore, and then there was one general's wife in Jaipur who had false high D-dimers on the photo-optic. So it's very, very important to know your equipment and the issues that there can be with the equipment. So whether you're using a photo-optic equipment or are you using an electromechanical, and the positives and negatives. So that's also very, very important in quality assurance. I'm not going into the details. Everyone who uses the equipment will read up about it and know it. Then we come to the patient-specific factors. Neonatal reference ranges are different. So all labs on their track care have the adult reference ranges. So you should put the neonatal reference ranges till 6 months of age because they are higher, because the vitamin K dependent factors are reduced. There's also another important issue of factor 9, which can be the reference range till age of 6 months is different from adults. So if a 4-year-old child's factor 9 has been done, you will, if you look at the adult reference range, you will think it's low, but it's in reality, it's not low. And we've had one patient who came at the age of 22 years to us, and at the age of 6, he was diagnosed as factor 9 deficiency, and he had a prolonged APTT, 120 seconds. He was just a factor 11 deficiency. So these are very, very important issues. Wrong diagnosis for almost 14 years he had. So physiological variation is also there. We know protein S is low in pregnancy. So if you do a protein S and you say, oh, there's a protein S deficiency in this lady and it's been tested during pregnancy, that's an issue. Fibrinogen and D-dimer are almost 2 to 3 times the normal value in the 3rd trimester of pregnancy. So you do a D-dimer and say, oh, she's got a DVT. No, D-dimer doesn't work in pregnancy for DVT. There are other guidelines. There are other scoring systems. So that's very, very important. Similarly, acute phase, you may have rise in fibrinogen, von Willebrand factor, and factor 8. You want to diagnose a lady who has menorrhagia and now she's pregnant, you do her von Willebrand antigen, it will be normal because it becomes 4 times the normal value. So these are very, very important issues to understand. And also, as I already discussed, the photo-optic system, elevated bilirubin and lipid levels will cause havoc sometimes in the optical density measurements. So when we talk of quality assurance, we talk about the preventive aspect, we talk about the assessment and the corrective aspect. So the preventive is what we do to get accuracy in our tests, the maintenance, calibration of the instruments, training of the personnel, knowledge development. Then is the assessment part, for which we run the standard graphs, we have the LJ curves, and we use the Westgard rules. I will not go into the details of that because the Westgard rules and the Six Sigma rules are discussed ad nauseum and everyone knows about them. But there are other issues because the best of the laboratories sometimes come up with the wrong results because of the lack of knowledge about coagulation. So, and then there is the corrective activities which have to be done. And that is the continuous process of quality assurance. You may have to do all kinds of troubleshooting. And this is the Westgard Sigma rules. I'm not going into details, but at least 2-level controls have to be used. And in factor assays, etc., we may have to use a 3rd-level control. And we should know, we should evaluate our Westgard rules very, very judicially, because somewhere you have a very low antithrombin and you say it's out of the range, but that's how the disease is. So that's very, very important to understand the Westgard rules and use it. So basically our quality control is looking at what are the errors and how we can change. These errors can cause change in diagnosis or treatment, which may not be necessary for the patient. So we have to have consistent, accurate, and reliable results. It should be applicable to our own population. So that is whenever we get a new lot, we take the manufacturer's range, but do revalidate it in 20 normal controls whenever there is a change of a lot. So this is very, very important. But as I already said, we have to know it. Low factor assays may show you that everything is going out in the Westgard, but then you have to use this intelligently. Otherwise, you'll be unnecessarily rerunning, revalidating to recorrect this. So it's very, very important to understand that. And the guidelines of recalibration are the same as for any others. If you have 2 level controls which are out, you go in for recalibration. But if the QC is out, you may have to run PT material and you may have to run independent controls, because these are the issues with coagulation. It is not just like simple chemistry. So that's important. So we move on to another case. This was an interesting case of a combined protein S and antithrombin deficiency. Antithrombin deficiency, bad thrombophilia, lifelong anticoagulation is what is suggested, as Dr. Amar Das Gupta discussed today. So this was a 29-year-old young officer when he came to me. So when he had this problem, he was 24. He had a mesenteric and a splenic vein thrombosis and a splenic infarct in high altitude in 2005. He was evacuated via Leh to Chandigarh, and he was operated by the GI surgeon and the vascular surgeons. Tests were done in a reputed private lab where he had normal protein C but had combined protein S and antithrombin deficiency. Now, with this diagnosis, he was put in the armed forces. They are put in low category for life, and they are reviewed every 2 years. So he was told lifelong of anticoagulation, and those days it was vitamin K antagonist. He was on warfarin. And when he came for his recat, the vascular surgeon sent him to me. I was at the Armed Forces Medical College, Pune at that time. And by that time, I had some publications and research on high altitude thrombosis in blood and thrombosis research on pathogenesis. So the first thing I did, I took his sample in EDTA, put a sickling test, and took his sample in citrate and did put in for antithrombin, because antithrombin is not affected by vitamin K antagonist. And lo and behold, his antithrombin was absolutely normal. We stopped the warfarin, put him on low molecular weight heparin, and 3 weeks later, we did the protein S levels, and they were absolutely normal. Protein C and protein S are vitamin K dependent anticoagulants. So he did not have a combined protein C and S antithrombin deficiency. He was just a sickle cell trait. And if you hear what is written about the Andes in the US, they say the black canary does not sing well on the Andes, because the American Africans have a lot of sickle cell trait. And once they go to the Andes, there are all issues of them developing splenic infarct or splatnik vein thrombosis. There are a lot of literature reported in literature. So he was just a sickle cell trait. So from a lifelong anticoagulation, he was just told that don't get into hypoxia, don't go to high altitude rest, all is normal. So that's so important in coagulation. So it's very important for thrombosis studies. Thrombophilia, you have the sample collected on an empty stomach. Individual should be off vitamin K antagonist for at least 2 to 3 weeks. You can put the individual on low molecular weight heparin at that time if you can't stop, because here we did not know, we didn't stop till we realized he was just a sickle. If someone is on DOACs, they have to be off them for 48 hours. 12 weeks after the acute event is the guidelines. Sometimes it's done in the acute event. If it's normal, you don't need to worry. But if it is abnormal, there should be a flag put by the lab reporting, please repeat after these could have been utilized in the acute event. So whenever you have the samples, because you have to multiple tests to be run, including APC resistance, you make multiple aliquots and freeze, because repeated freeze thaw will be bad. So whichever test is run in a batch, you then thaw it for that. It should be a platelet-free plasma. And as Dr. Dasgupta said, you should do a PT and APTT. And if it is prolonged, we don't do the test. So that's the rejection issue. So very, very important. So as we discussed, what do we want from your coagulation assays for quality assurance, and how do we do this? We need precise results, robust assays, accurate results that can be used to aid in diagnosis, and reproducible results. And you need to have good SOPs. You have to have effective quality control practices. You have to enroll in proficiency testing programs. In India, we have the CMC Valor coagulation. We have the BioRad. If one has the money, one can go for the CAP or the NKU class. Good laboratory practices, and what is most important, which is missed out because the technicians are doing it, and everyone without the knowledge of coagulation is running the lab and doing coagulation tests, is to understand coagulation itself and the impact these results will have on patient care. I come to another case. She's an 84-year-old lady. She had history of not eating well or drinking fluids, so had some pre-renal azotemia. Mother of a doctor, colleague, friend, admitted. They were to start her on low molecular weight heparin because she was having bedridden. She was an old case of query stroke, atrial fibrillation. So they sent her coagulation test. APTT, PT both for prolonged. Fibrinogen was normal. We asked, is she on any DOAC, any anticoagulant? They said, no, we are just going to start low molecular weight heparin today. We did a repeat sample, again the same issue. We did the thrombin time, it was unrecordable. Went back, saw the case sheet, atrial fibrillations, she had been on dabigatran. Dabigatran is a direct thrombin inhibitor, which had been stopped 2 days prior, so that effect should have gone. But because she had atrial fibrillation, she was also on amiodarone. She was on PPI inhibitors, and now she had developed renal derangement. So all these together caused the increased effect. You know, there was an issue, the cardiologist said, but we give dabigatran, it's not monitored, so how will it affect the PT and APTT? No, it does affect the PT, APTT, and thrombin time is unrecordable. So that is it. It's not directly proportional. It's not used for monitoring, but it does affect. So that knowledge has to be imparted, and we have to know the drugs which will interact. So the way to remember is the Fab4, Flagyl, amiodarone, bezitracin, that is Septran, and fluconazole. They can create havoc with oral anticoagulants as well as with direct thrombin inhibitors. So when we look at the causes of prolonged PT, APTT, and thrombin time, qualitative and quantitative effects of fibrinogen, dysfibrinogenemia, hypofibrinogenemia, effects of heparin, DOACs, and it's very, very important in lupus anticoagulant testing also. You get someone for lupus anticoagulant testing, and I remember there was a question in the question box, what test for lupus anticoagulant? They have to be 2 coagulation-based tests. So I'm answering that question also. One, anti-10A, DRVVT. The other can be a APTT-based. If you're silica clotting time, if you're going by the ISHD guidelines, you can go by the CLSI guidelines and have another test, but 2 tests are mandatory, and then IgG, IgM for anticardiolipin and IgG, IgM for anti-beta-2 glycoprotein. Now, when you're doing lupus anticoagulant testing, if someone is on rivaroxaban or apexaban, which are anti-10A DOACs, or on antithrombin or heparin, you'll get false positive. So it's very, very important when you're getting a positive lupus anticoagulant in your lab, do a TT, keep it as part of the bill. If it's increased, it's not lupus anticoagulant. Pick up the phone, talk to the clinician, push in and find out the details. Sometimes you'll just have to ask, is he old? Has he atrial fibrillation? He may be on dabigatran. Very, very important. So like in this particular case, we have dabigatran, the half-life is 14 to 17 hours. But if there's renal impairment, 80% is excreted by the kidney, it goes up. And here we had PPI inhibitors and we have also amiodarone. So that caused the problem. Moving to another case, post-surgery for Splatnik main thrombosis, a 32-year-old male. was put on unfractionated heparin by the GI surgeon, was being monitored to get a APTT of 1.5 to 2.5 of the mean control. But there was no response. So they increased the dose of heparin, no response further. So he suspected heparin resistance, consulted me. We did antithrombin levels. That's what happens in heparin resistance because heparin acts through antithrombin. That was normal. We performed the anti-10A assay, and that was slightly over anticoagulated. You can see the normal range. So if he had further increased, this patient would have bled. So we had the anti-10A became very, very important. It is very, very important to have these results accurate, because if they are inaccurate and there's over anticoagulation, the patient would bleed, and the vice versa, clot can occur also. Now, why he was not responding, we did the factor 8 assay and it was very high. Now, APT depends on 11, 12, 9, 8, and 10, 5 to 1 common factors. So when factor 8 is very high, the APTT will not show response to heparin. So that's very, very important. So this is the problem of APTT monitoring for heparin. APTT can be elevated because of warfarin therapy, because of lupus anticoagulant. So a person with thrombosis because of lupus anticoagulant again cannot be monitored by APTT. You have to do anti-10A assay, factor deficiencies or liver disease. And here the response will be exaggerated. And we have a patient in our hospital at the moment who's had this kind of issue. Even with the APTT of 100, the anti-10A activity was not adequate because the cause of the splenic vein thrombosis in this patient is a lupus anticoagulant. So you can anticoagulate and they may have more thrombus. And shortened APTT because of increased factor 8 or factor 1 can cause over anticoagulation, as in the case we discussed. So the ideal test is anti-10A assay. Comes in the problem of cost. So that is an issue. But there's another issue with anti-10A assay, and this we saw during the COVID era, because a lot of patients were getting low molecular weight heparin or heparin, and the sisters or the residents from the ward, 10A karana hai, they were sending 10A factor assay. Rather than sending anti-10A activity assay, we were getting 10A. So we had to get the bills cancelled. At times it was done by the staff in the evening. The patient is from the COVID ward. Why are you getting a factor assay done? It was the anti-10A activity assay and not factor assay. And this issue is also have seen with patients who sometimes come with reports for thrombophilia workup. Everything has been done, but instead of APC resistance for factor 5 lead-in, the clotting-based assay, factor S5 assay has been done in that. So this issue is also very, very important. The labs miss it out, the clinicians miss it out. So that is very important for quality assurance. So it's a prolonged APTT coming up. That could be because of inhibitors or factor deficiency. So you have the mixing study. It's very, very important in mixing not to call it 50%. Please either do the Rossner's index, very easy to remember, MCP, M for mix, C for control divided by the patients. Less than 15% factor deficiency, more than 15% it is inhibitors. So that's what we do in our lab. So we have to look at the analytic, we have to look at the pre-analytic and post-analytic as key indicators for quality assurance. And we have to plan, do, check, and act. So if in the pre-analytic there's something wrong, find out where it is happening. Is it happening from pediatric cardiology? Check and then recheck and get it corrected by retraining. Similarly, you can do it for the factor 10A, and that's what we have done in our hospital. And just to conclude, the main issues in coagulation, quality assurance, your PPP, your INR verification, correct reporting of D-dimer, very important, linearity and standard curves, education, heparin therapeutic range, and most important, providing information to the clinicians regarding impact of anticoagulants. And with that, I conclude my talk. Thank you.
Thank you, ma'am. It was a very good insight about the quality in coagulation studies. There's a question asked by Dr. Reena. Can there be any reference for age-wise reference range for coagulation factors?
It's available in the literature. You have the British guidelines. You can validate it in your lab sometimes, but the age reference ranges are available and they are should be used in the laboratory.
Thank you, ma'am. And there's a question from our previous speaker that Dr. Banali has asked. One medical college lab has IL and Stago both for D-dimer, and they are finding difficulty in harmonizing. How they can harmonize the two instruments?
You will not be able to harmonize the two instruments for D-dimer. Stop using the IL. You'll get better quality reports on the Stago. That's what we are doing. I do everything else on IL, but my D-dimer is on Stago. Because the technology is different. You cannot harmonize the two. You'll go mad and you'll never be able to explain the auditors what is happening when they come to audit.
Thank you, Dr. Kotwal.